Hello everybody and welcome to today's webinar. Budget Impact Analysis presented by Dr Máirín Ryan, Director of Health Technology Assessment for the Health Information and Quality Authority. I'd like to welcome everybody along today. Thank you very much for coming. We're delighted to have you. I'm just going to say a little piece about Máirín just to start. Máirín was appointed Director of Health Technology Assessment in September 2007. She and her team were responsible for conducting assessments of health technologies, including drugs, devices, diagnostics and public health programs. These assessments help inform safe and effective health policy and health service decisions which are patient-centred and deliver value. I'm going to be handing over to Máirín in a few moments to start the presentation, but firstly I'd just like to say if you have any questions during the webinar, please feel free to ask them. Any that we don't get to, we will follow up with an email afterwards. Okay, I'm going to hand over to Máirín now. Máirín, are you there?
Yes.
Hi Máirín, I'm going to hand over to you to make you presenter now.
Okay.
Great, Máirín, and I'm going to mute myself and I'll come in then at the end of the presentation.
Okay. Is my screen up now?
It is indeed, yep, it's on the first slide.
Okay.
Perfect.
Okay, great.
Thank you, Máirín.
And can I just test that as I go down through the slides that they're moving on for
Yeah,
everybody?
no problem.
I'll just go on to the first slide there.
Yep,
Does that
that's
come up?
perfect, it did, yes.
Brilliant. Okay.
Brilliant.
Thank you very much.
Thank you.
Okay. Hello, everybody. As you've just heard, my name is Máirín Ryan and I am the Director of Health Technology Assessment in the Health Information and Quality Authority in Ireland. We're the body in Ireland that has the statutory responsibility for health technology assessment for the country. And part of our role is to provide advice to inform major health policy decisions and major health service decisions. And we do that through producing health technology assessments. Now, in terms of health technology assessments, just to set the scene a little, a health technology assessment is essentially the means by which we provide all of the information that the decision maker needs to make an informed decision when they're deciding whether or not to invest in a new technology, or sometimes it can be to disinvest in a technology as well. And the information is collected in a systematic, transparent, unbiased and robust manner. So essentially it's about producing a research-based evidence report. And we consider a number of domains when we're doing that, which include things like information on the safety of the intervention, what benefits it will deliver, so clinical effectiveness, is it good value for money, cost effectiveness, organizational impact, resource implications, social and ethical issues, sometimes medical legal issues, and absolutely always we have in there something on budget impact. So that's where budget impact analysis sits. It sits within, for us in any case, it sits within the overall framework of health technology assessment. And you may know that in Ireland we've gone through an economic crisis. We're still going through the economic crisis since 2007. So for us, with many other countries who are going through austerity, we are still having year-on-year reductions in our health budget. So the budget impact of any new technology that we're looking at is of crucial importance, because regardless of whether it's cost-effective or not, whether it's affordable or not is a key consideration. So budget and impact analysis is about answering that question. So essentially, what is it? It's a tool to predict the financial impact of the adoption and the diffusion of a new technology into a healthcare system with fixed resources. So a scenario that we all face, I think, day by day. And it addresses that affordability question. It's an analysis of the added financial impact of the new health technology for a finite period of time. So that's important information for the decision maker, is that if you implement the new technology, what will be the total cost of care, but then also what's the incremental cost compared to what we're paying to manage that condition at the moment. So in terms of what health technologies are considered, It essentially can be any technology that's used to promote health, to diagnose or treat disease, or used in rehabilitation or long-term care. So any technology that's used in healthcare. It can be drugs, it could be medical devices, it could be diagnostics, it could be surgical procedures, it could be organizational support systems such as IT systems, or it could even look at organizing the way healthcare, a particular aspect of healthcare is delivered in your healthcare system. So all of those technologies can be subject to a budget impact analysis. And why do we do it? Well, as we've been saying, it's required to make an informed reimbursement decision. So before the decision is made to invest in a new technology, or alternatively occasionally happens to disinvest, the decision maker needs this information. The reason that they need it is that the new technology may have increased acquisition costs. Very typically, I suppose, technologies that are brought to the market deliver additional clinical benefit, at least the innovative ones do, an additional clinical benefit over what we have already, but invariably that comes at an increased cost. But the new technology may have cost offsets. For example, you may see a technology that results in a reduction in the adverse events. And adverse events can sometimes be costly. So, for example, if we look at a new chemotherapy agent, one that causes less suppression of the immune system, well then that may decrease the need for expensive prophylactic measures such as growth colony stimulating factors, and it also decreases the risk of having an adverse event such as neutropenic sepsis, which is very expensive to manage. So there can be cost offsets associated with reduced adverse events. You also may find that it may be associated with decreased inpatient costs. For example, robotic surgery is more expensive than more traditional means of surgery because of the cost of acquisition of the robot itself. But for most indications, it has been shown to be associated with a reduction in inpatient care. So patients recover quicker and can be discharged from hospital, so there are cost offsets in terms of hospitalization costs. The new technology may have a different impact on different cost centers. So different cost centers such as drug costs, laboratory costs, or staff costs. An example of this would be if you have a drug that is usually administered intravenously and requires admission, for example, to the day ward of the hospital for admission. If an oral alternative becomes available, then the cost shifts to the community drugs budget, but you get cost offsets in the hospital setting because you've decreased cost of day ward stay, you've saved on that. You may have saved on aseptic preparation of the intravenous product. You've saved on IV infusion costs. You may have saved on adjunctive therapy such as, say, for example, antiemetics, and you'll also have saved on staff administration costs. So it's required for an informed reimbursement decision that we've teased out all of these issues and we have the information available. So then the issues to consider in a budget impact assessment. Very recently in Ireland, in fact currently, we are in the process of revising our national budget impact analysis guidelines. They were first developed in 2010 and they're currently being revised to conclude at the end of the year. They're at consultation at the moment. And in those guidelines, which I provided as a reference material at the end of the presentation, we go through the various issues that need to be considered and need to be addressed in conducting a budget impact analysis and then also need to be reported on. So these are listed here on the screen and we're going to go through them one by one. So the first one that we look at is perspective. So when you're doing a budget impact analysis, it's very important to know what perspective you're using. In other words, what's the viewpoint from which the study is to be conducted? Is it from the payer's perspective? It might be a sub-budget of the health budget. Maybe it's a societal perspective. So when we look at the payer perspective, we're essentially considering costs that are falling on the health and sometimes on the social care system only. And this would be typically the perspective that we use in Ireland. It's used in the UK and in some other countries. In other cases, we may be particularly concerned with just one aspect of the health budget. So we might be only interested in the costs that are falling on, for example, the drugs budget, if we have a narrower perspective. An alternative, much broader perspective is to look at societal perspective, where we consider other costs. For example, We may look at the costs falling on patients of accessing healthcare, so transport and sometimes even accommodation costs, costs of paying for the care of dependent relatives so that somebody can access healthcare for themselves. We may also look at things like lost productivity due to either accessing healthcare or due to ill health. And lost productivity can, of course, result in loss of income to the individual, but it can also cost the state because you can have costs of unemployment benefit that fall on the social care budget. And then you can also, of course, have decreased income taxation, so that results in a decreased revenue to the exchequer. So societal costs is, if we take a societal perspective, we include the health and all the other costs that are associated with healthcare and managing that particular condition. In Ireland, we take the payer perspective, so we look at the perspective of the public healthcare system. But in some other countries, such as in the Netherlands, for example, they take the broader, more societal perspective. And some other countries are starting to move towards there now. What you find if you take the societal perspective is that it can impact both the costs of the intervention and also the costs of the offsets. And it can result in either an increase or a decrease in the total budget impact. So it's not necessarily predictable. But it tends to be specific for a particular healthcare setting, what the decision makers have decided that they want to consider when it comes to budget impact analysis. Then in terms of the technology or the intervention that we're looking at, it's important that we know enough about the new technology that we can differentiate it from the comparators, from the standard of care that it's replacing. So we need to know about the treatment indication. We need to know why we are using this particular intervention and which patients will use it, which patients will access it. We need to know about how it will be used, for example, the dose of a drug, how it will be administered, where the place for that intervention is in the treatment pathways for individuals who have the selected condition. We need to know what benefits it will deliver. So what are the positive clinical outcomes, but also we need information around the adverse events, as we've mentioned earlier. And then we need to know what else needs to be in place to enable use of this intervention. So what does it mean for healthcare staff? Are there training requirements? For example, with robotic surgery, there is a steep training curve for surgeons who start to use the robot for the first time that needs to be taken consideration of. Do we need adjunctive interventions, such as adjunctive drug therapy to manage side effects like nausea, IV infusions, and so on? We need to know about the healthcare setting that the technology will be used in. Sometimes the technology may be associated with a capital investment. We may need to invest in accommodations, say, for example, for a new screening service, or we may need to invest in equipment. For example, if we move to robotic surgery, we need to invest in robots, which are quite expensive. We also need to know the same level of information about the comparator. And the preferred comparator in a budget impact analysis is routine care. So what's the standard of care practice for managing this particular condition at the moment before we introduce the new technology into the marketplace? So in terms of the preferred comparator, routine care essentially means the technology that's most commonly used for that indication in your healthcare setting. So it needs to be specific to the healthcare setting that we're conducting the budget impact analysis in. Sometimes there's more than one comparator. So there may be more than one technology that's being used. I've mentioned robotic surgery a number of times because that's the health technology assessments that we've conducted here. And there the comparator for robotic surgery is laparoscopic surgery and open surgery. And what we have at the moment for conditions like prostatectomy and hysterectomy is that we have a mixed treatment pattern. So there's a proportion of patients currently having open surgery and a proportion of patients currently having laparoscopic surgery. So if we're to introduce robotic surgery, it's compared against a weighted average of the two alternatives. Occasionally, we may need to include as a comparator a technology that doesn't have a marketing authorization for that indication. And we do that in circumstances where that is the standard of care. So sometimes you find that clinical practice is dictated that the treatment that's being used for a particular condition, even though it might not have a license or a marketing authorization for that indication, that's the treatment that's being commonly used. So when it comes to the information that the decision maker needs to know, that's what they want the comparison against. They want the comparison against what's being used as standard practice at the moment, and then what's the incremental cost of introducing this new technology if it's to be adopted instead. Of course, when we're looking at comparators, we do need to have information on the efficacy and the safety, even if it's an unlicensed comparator. And sometimes we find with truly innovative interventions that no intervention may be the appropriate choice for the comparator, because perhaps up to now we haven't had a treatment intervention for that particular condition. We also need to decide what's the time frame over which we're going to conduct our budget impact analysis. So this is usually represents the time horizon that the decision makers will plan resource use over, and it's often specified in the region of around 5 years. Sometimes less than that is perfectly reasonable and useful. Sometimes it's more. The reason it may be more may be because it takes longer than that to get to steady state. So by steady state, what we mean is that the proportion of the population that's using the technology has plateaued out. Now, it may still be increasing, but if it is, it's increasing solely due to demographics such as population growth and aging of the population. But diffusion of the technology through the marketplace has plateaued. And time to steady state depends on the rate of diffusion and the uptake of the technology. So sometimes you may have slow diffusion, and it may be due to capacity issues. For example, particularly if something requires major capital investment, it may take time to invest in the accommodation or the equipment that's required. Sometimes also there are learning curves. So for example, with robotic surgery, surgeons take some time to get up to speed with using the robot as opposed to the other approaches to surgery. So it takes a number of years before you can assume that your robot will be used to full capacity. And sometimes we find that when it comes to particularly looking at the cost offsets associated with the clinical benefits of the technology, that particularly for chronic diseases, it may take a long time for those cost offsets to peak. And you also find the same with screening programs and with vaccinations, etc. So public health interventions, it may often take a long period of time before the benefits are realized. Also with some technologies, we need to consider some of the technological issues, particularly, for example, with implantable devices. Maybe after a number of years, the battery will need to be replaced. So we need to consider in our budget impact analysis that at a set period in time, you may need a surgical procedure to replace the battery or to replace the device. In terms then of other considerations that we need to be cognizant of, we need to know about our target population. And our target population essentially is the individuals with a given condition who might avail of the technology within the specified time horizon. So when we're trying to model or to estimate what our target population is, we'll use epidemiology data to inform the reporting of the prevalence of the disease, the incidence of the disease, and then also the exiting of individuals from the cohort through mortality. So essentially, what we're looking at is that we're looking at an open cohort which mirrors the real-life situation. So every year, some individuals will leave and others will join. So the cohort, the size of the cohort is essentially the sum of the prevalent cases plus the incident cases or the new cases that year, minus those then who recover and leave the cohort and those who die each year. And we also may, with some technologies, we may need to consider those who may enter the cohort because this new treatment is available. So with the treatment that's available at the moment, some individuals may not even consider treatment. But when something comes along that's truly innovative and offers a benefit, you may have new individuals that are coming into the particular cohort. So you need to be cognizant of those issues. In the budget impact analysis, we need to report the absolute size of the target population, so the number of people who we estimate are going to take up this new intervention. And when it comes to estimating the uptake, this is based on information such as the proportion of the overall cohort who are suitable for the intervention. Sometimes you have contraindications that will rule out some portions of the population. We need to be have some idea of what adherence and persistence will be. So adherence in terms of the proportion of treatment that somebody will actually take, and then persistence, the length of time that somebody would persist to take the particular therapy. And often you can get that information from clinical trials. Sometimes you can get it from observational data from other comparable treatments. Sometimes this information comes through market analysis, and if necessary, we can get that information from expert opinion. We need to report the frequency of healthcare use, so for example, episodes of care. For example, with something like chemotherapy, we want to know the number of chemocycles. And sometimes we need to consider subgroups. So consideration should be given to including subgroups if they can be identified by a plausible rationale. So options might include, for example, by indication. So we may look at whether a particular treatment should be used as first line, as second line, or maybe as salvage therapy. Sometimes we look at subgroups by setting, for example, whether the intervention is going to be used in the primary care setting or whether it's going to be used in a hospital setting. And sometimes we may look at an intervention by patient group. For example, we not that long ago did a health technology assessment looking at prion filtration to improve blood safety by decreasing the risk of transmitting VCJD through the blood supply. And it was felt that it was plausible to consider children as a subgroup because of the fact that if they receive a blood transfusion as a child, they have a longer time to develop a disease, and in this case VCJD can take up to 40 years before it presents as clinical disease. Also kids were considered as a plausible subgroup because there may be a societal preference to protect children more than adults. So we considered that it was reasonable to look at children as a plausible subgroup. But of course, while it might be a plausible subgroup, it also then threw up the issue of whether it was actually implementable to provide children with filtered blood if the rest of the population was receiving unfiltered blood, and there was a risk of serious harm while waiting for filtered blood, and that would outweigh the very low risk of acquiring VCJD from unfiltered blood. So there are lots of other aspects that need to be taken into consideration as well. So then we'll move on to the nuts and bolts of it, to costing. Costing depends on the perspective. Now, I'm afraid there's actually an error in the slide here. What it should say is that the costs that we look at should be categorized as direct medical costs. So this is actually the costs that fall on the healthcare budget of providing the particular intervention. So the acquisition costs of the intervention itself and all the other adjunctive costs that are borne by the healthcare system. The next category should be direct non-medical costs. So here we're talking about the cost to the patient of accessing care, so it may be transport to the hospital or paying somebody else to look after dependent relatives. And then the final one should read indirect costs, and here we're talking about lost productivity costs, as we discussed earlier. And when it comes to actually estimating costs, there are 3 steps involved. We need to identify any resource use that's going to change with introduction of the new technology. We need to quantify the extent of those changes, and we need to measure the cost of those changes. So in terms of resource use, all the costs that are directly associated with the intervention, plus then any adjunctive interventions such as concomitant medications, the cost of managing adverse events, the cost of administration such as costs of the setting and the staff, they all need to be included. We also need to include any cost offsets, and these include reduced costs of adjunctive interventions and then reduced healthcare consumption, like for example we mentioned earlier, reduced hospitalization associated with robotic surgery. And then we also need to look at costs that are not directly related to the intervention that's been, and in our case, in Ireland, we exclude these from the analysis. So these are other healthcare costs that are now falling on the system due to the extension of life. So the new intervention comes along, you've got improved survival, but then those individuals who now survive longer encounter other healthcare costs associated with other conditions. In Ireland, we don't include that in the budget impact analysis, but it's not a standardized practice. Everywhere in the world, some countries do and some countries don't. In our case, we don't, because more from the pragmatic reason that other healthcare costs don't usually occur in the time frame of the budget impact analysis, so they don't actually impact. We need to quantify the resource use that will change, and to do that we need to depict the treatment sequence or the clinical care pathway for the current scenario, so treatment as it is at the moment, and then for the new intervention scenario. So we introduce a new technology and we now look at the impact that that has on the treatment sequence, the clinical care pathway. In terms of how resources will change in the new intervention scenario, we can get information to inform that from randomized clinical trials, from observational data, and then also from expert opinion. And then in terms of actually determining the costs, so we've identified the resources that are going to change. We know how much they're going to change by, but we need to put a monetary value on them. So we need to estimate the unit costs. In some countries, there are unit cost databases where you can find many of the important costs that you would need for a budget impact analysis. In some countries, such databases don't exist, but there may be administrative databases where there's actually payment data that will give you a good proxy of what the unit cost of a particular intervention is. And sometimes you have neither available. You actually have to do a microcosting analysis where you go into the particular setting and you actually do a time and motion study and cost up all of the resources that are used. But what you do is you focus on the differences between the current scenario and the new intervention scenario. So because that's what you're interested in, is what's going to be the incremental cost difference. There are some other challenges when it comes to looking at unit costs. Sometimes you may find that there are unit costs available, but they may not be current. They may be from a number of years ago. And one of the techniques to try and deal with that is to use the Consumer Price Index. So the Consumer Price Index reflects year on year the inflation in costs. So you can use it to inflate costs that are measured in a particular year to their present value. And the Consumer Price Index data is something that is particular to each country and is published by each country. And some countries, like in Ireland, will have sub-indices. So, for example, we have a health consumer price index, which particularly reflects healthcare inflation, and that's the one that we would use if we're inflating costs from another year. In the budget impact analysis guidelines that I'm giving you the reference for at the end of this presentation, at the back of that guideline document, there's a worked example of how to inflate costs using the consumer price index that you can refer to. In other cases, you find that you may not be able to find cost data from your own country, but somebody may have done work to estimate the unit cost in another country, and you want to translate that then to your country. Rather than using currency exchanges, we usually use purchasing power parity. And again, the purchasing power parity index is essentially a means of reflecting what is the purchasing power of money in another country compared to your own country. And again, at the back of the guidelines for budget impact analysis, there's a worked example of how you transfer costs from another jurisdiction to your jurisdiction using purchasing power parity indices, which are publicly available. Another area that you sometimes need to look at is capital costs. And frequently you buy an item of equipment, or maybe ICT, you may build a building, but the costs need to be spread over the lifetime of that equipment. So again, at the back of the guidelines, there's a worked example of how we account for depreciation. So in other words, how we can account for the capital costs being spread out over the lifetime of the capital. And when we're measuring capital costs, we also need to include the ongoing costs of maintenance. So, for example, healthcare equipment will often need to be maintained on an annual basis and so on. So we need to include the cost of that in our capital costs. Again, at the back of the guidelines, there's an example of how we account for capital costs. When it comes to staff costs, we often use the midpoint of a scale if there's a scale available, but we do need to be careful to include not just the salary that's paid to the individual member of staff, but the total cost of employing that person. So it needs to include administrative and pension overheads. So for most healthcare systems, that kind of information will be available. Again, at the back of the guidelines, there's a worked example to show you how that's done in the Irish setting. Should be applicable to other settings as well, provided the data is available. We also do need to look at clinical outcomes. So although this is primarily focusing on the financial impact, we do need to look at clinical outcomes. We need to consider those clinical outcomes that influence the use of the technology. So its effectiveness, its safety, that impact on uptake. And then we also need to look at the need for further treatment. So for example, you've got an implantable device failure, then that will require further surgery. So in terms of this kind of data, we get data on effectiveness from randomized control trials. Sometimes from meta-analysis if homogeneity and quality of the data justifies that approach. And then RCT data may also be supplemented by observational data. And this can be very useful to enhance the generalizability and the transferability of data. But if you're using non-randomized controlled trial data, then as always we need to assess for risk of bias, validity, and so on, so that we can assess what the generalizability and transferability is to our own settings. In terms of safety, sometimes we can get this from randomized controlled trials. We can also maybe get it from patient registries. And all adverse events that are of economic significance should be included, so things like hospitalization, impact on adherence and persistence, and so on. Why do we need to look at clinical outcomes? Well, we need to determine the use of the technology and any cost offsets, so we get that from the effectiveness and the adverse event data. But we also need to provide data for planning resource use. So we need to know, for example, to be able to quantify things like cost offsets in terms of reduced bed days. And then for decision makers and planners, if we can provide them with data on benefits, then they can use that to justify the budget increases that will be demonstrated by the budget impact analysis. In terms of actually putting all of this information together then in the budget impact analysis model, when we do this, I suppose one of the most important aspects is that the structure of the model needs to be described clearly, and any assumptions that are used in the model need to be stated, and the sources of all data needs to be acknowledged. We need to describe how we have validated our model. And essentially what we're doing is we're calculating what's the budget impact in the baseline scenario. So in other words, where treatment is as it is today, the standard of care, and then we also need to model the new technology scenario. So what will it look like when we introduce the new intervention? The baseline scenario, essentially, it's a forecasted version of the current mix of technologies for the chosen population and also for the subgroups. And it forecasts the situation should the new technology not be reimbursed or not introduced. Whereas then the new technology scenario, this is a forecasted version of events should the new technology be introduced. But ideally, these forecasts should anticipate any other changes that are likely to occur in the market over the time frame. For example, the introduction of other new technologies or new indications for existing technologies. In terms of what the model looks like, sometimes for management of acute disease, a very simple static model can be designed. For example, the management of an acute infection or maybe surgery for an acute presentation. But very often, and probably I suppose increasingly so, we need to use a dynamic model, because this will allow for population size to change over the time horizon of the budget impact analysis, or for the disease state of individuals in the population to change over time. So you may find that when a new intervention is introduced, it changes the natural history and the natural progression of disease, but you need to be able to accommodate for that in the model. If it improves survival substantially, you'll see the increase in the size of your cohort over time. Your prevalent cohort will increase over time, so we need to adjust for that. In terms of a dynamic model, very often what we can use, if we're conducting our budget impact analysis alongside a cost effectiveness analysis, we can adjust the cost effectiveness model to calculate the budget impact analysis, but we need to adjust for it in terms of the population size needs to reflect the absolute population who will access the technology. We, in budget impact analysis, we include value-added tax, so any taxation, because that has to be paid for by the healthcare payer, whereas that, because it's a transfer cost, is not included in a cost-effectiveness analysis. And because we're considering costs as they occur in time, we don't discount in a budget impact analysis, whereas we do in a cost-effectiveness analysis. So if we just want to compare a budget impact analysis against a cost-effectiveness analysis, we can see that the differences fall under a number of parameters. So the key concepts that we're looking at in budget impact analysis is affordability, whereas the cost effectiveness analysis looks at value for money. The purpose of the budget impact analysis is to look at the financial impact or the cost of introducing the technology, whereas in the cost effectiveness analysis we're looking at efficiency of alternative technologies. We're trying to determine value for money. The time frame of the budget impact analysis is usually short-term, 1 to 5 years, whereas in a cost effectiveness analysis we're looking at the costs and impacts over a long term, often over the lifetime of the patient. Health outcomes are not included in the budget impact analysis apart from in determining health outcomes that are associated with specific costs, particularly cost offsets like adverse events, whereas health outcomes are a crucial part of the economic evaluation because you're expressing the outcome of cost effectiveness in terms of cost per life year saved or cost per quality adjusted life year saved, so it's crucially dependent on health outcomes. We don't discount in a budget impact analysis because we're looking at costs occurring in the year where they take place, whereas we do discount to current value of money in the economic analysis. And the results from the budget impact analysis are the total cost of managing the condition and the incremental costs of introducing the new technology, whereas in an economic evaluation the output is an incremental cost effectiveness ratio, so it's the incremental cost per unit of health outcome achieved. So while there are substantial differences between the budget impact analysis and the cost effectiveness analysis, by varying the inputs, we can use the cost side of the cost effectiveness analysis to estimate the budget impact, which is frequently what we do. One aspect that's very important to look at in terms of budget impact analysis is to look at the uncertainty. So very often there's uncertainty around the structure of the model that we use, but there's also substantial uncertainty around the values or the parameters that we put into the model. So to examine uncertainty, we usually conduct scenario analysis to evaluate plausible scenarios, and we also conduct sensitivity analysis to evaluate the uncertainty in the budget estimates due to uncertainty in the model, that's the structural uncertainty, and also then parameter uncertainty. So the parameters that can be examined, any parameters, basically any data that goes into the model, we can look at the uncertainty around those parameters. But the ones that we would nearly always consider would be things like the population size, uncertainty around the rate of uptake, and maybe uncertainty around the costs, both the cost of the intervention and of any offsets. What we find with costs, there may or may not be any evidence of variation, but it's often pragmatic to vary the cost data by plus or minus 20%. And then also in some cases to look at what would be the impact of variation in reimbursement, for example, if the drug comes off payment. We often look at univariate sensitivity analysis. And the univariate sensitivity analysis is essentially where we examine the impact of every variable in the model varying across its plausible range of values while holding all the other values at their baseline or their best guess value. And then the resulting difference provides some indication of how sensitive the results are to any substantial change in that parameter. So a univariate sensitivity analysis gives you an indication of how sensitive the model result, the actual point estimate of the budget impact, is to variations in the value for a particular parameter. So it might be variation in the uptake, it might be variation in the costs, and so on. In a multivariate analysis, then, we vary 2 or more parameters simultaneously to study the combined effect. And that may be represented as a series of scenario analysis, which represents subsets of multivariate analysis. So an example of this would be where we do a best case scenario and a worst case scenario. So a number of the parameters are set at their extreme values, and we see what happens in the best and the worst case scenarios. And then another alternative is to conduct a probabilistic sensitivity analysis. In a probabilistic sensitivity analysis, for each of the key parameters, a probability distribution is applied using the plausible ranges for that key parameter rather than a point estimate for each parameter. And this allows the uncertainty around all the parameters to be considered simultaneously. This is the preferred method for looking at sensitivity analysis for budget impact analysis in Ireland, but again, that's not standardized practice internationally. Some countries do and some countries prefer to just do the scenario analysis. Then when it comes to reporting, there are certain requirements for reporting a budget impact analysis according to best practice. We need to report the resource use for each year in natural units. So we don't just report the cost, we also report the resources that are used that go to make up that cost for each year, and that's very useful information for the decision maker. We present as disaggregated costs, so we'll present by categories of costs for each year, so how much will be spent on staff costs, how much will be spent on consumables, and so on. As mentioned earlier, we always report both the total budget impact of adopting the new technology and then also the incremental cost. So what's the difference between the cost of having the new technology diffused through the system compared to the standard of care before the new technology was introduced. We may report the data disaggregated by subgroup if that's appropriate. And we'll report any scenario and sensitivity analysis, including the range of each parameters that were included in the sensitivity analysis to give the decision maker a sense of what the uncertainty is around the point estimate for the budget impact. So they have an idea of what the point estimate is, that's the best guess, but then also the degree to which that might plausibly vary. So I'm just going to go through a couple of examples from work that we've done recently. In terms of reporting budget impact, I've mentioned this a number of times where we conducted a HTA to compare robotic hysterectomy versus the mix of laparoscopic plus open hysterectomy. And then when it came to reporting the budget impact, we reported the budget impact over time, and then the total budget impact, the total 5-year budget impact was reported as 4.5 million. In terms of what a univariate sensitivity analysis looks like, we present the data in tabular form, but we also usually present it as a tornado plot. So you can very quickly see, along the left, you have a list of the parameters that went into the budget impact analysis, or at least some of them. And then you see the extent, if you vary each of these at the extremes, what impact that will have on the total budget impact. This is another HTA that we did comparing, examining a national deep brain stimulation program. So this is an intervention that's used in patients with movement disorders. And currently, patients are assessed here in Ireland, but then they are sent to the UK to have the surgical procedure performed. And then the patients travel back to Ireland, and their ongoing care is in Ireland. And we were asked to look at the budget impact and other aspects of bringing the service back to Ireland. So here you can see that we reported the budget impact in terms of what the budget impact would be to provide the service in Ireland each year for the first 5 years, how much it costs to provide it in the current setting where we send people abroad for the surgical part of their care, the difference per year, and then the cumulative difference over 5 years. But we also report the resource requirements by year, so that planners will know that if they make the decision to bring the program home to Ireland, this is what they will need in terms of increased resource requirements. We also then can report the cost elements according to the different cost budgets. So here you see the cost reported according to staff costs, the inpatient per diem costs, the cost of surgery, the cost of imaging, and so on. So we can see the proportion that falls on different sub-budgets within the healthcare system. And we also reported in terms of the overall cost of care for these patients. You can see what proportion of the total cost is attributed to each step in the patient's care, from their initial assessment to when they go to the UK to have the device implanted, the cost if they need to have the device removed or the battery replaced, the interim reviews, and the ongoing reviews. So that kind of information, again, is very important for planners if they decided to implement a new technology. So then, just to conclude, the budget impact analysis is very important for reimbursement decisions. If you're doing cost effectiveness analysis and a budget impact analysis, it's the same data is used to populate both models, but there are structural differences in terms of how you use that information. It's necessary to report both the total cost of introducing the new technology and then also the incremental budget impact compared to the situation before the technology is introduced. If we have a standardized approach, which is the idea, I suppose, of having national guidelines, and then there are also international guidelines, for example, the ISQua guidelines, a standardized approach, if it's used in a healthcare setting, it allows for meaningful comparisons, and it's a quality-assured way to proceed and to be recommended, I think. And then when you're doing a budget impact analysis, the methods need to be clearly explained and sufficient data provided to allow for validation for external validation so decision makers can be confident in the information that's been presented to them. So here on this slide, I've just provided you with a number of references, our own guidelines, the ISQua, guidelines of budget impact analysis, and then also referred to the health technology assessments that I've used as examples in this presentation. And then that's my contact details in case anybody would like to follow up on anything they've seen in the presentation today. So thank you.
Hi, Maureen. Thank you very much. That was fascinating. There's an incredible amount of detail in there that you managed.
It's a detailed area of work. It's technical.
It surely is. So I just have 2 questions here. While I think everybody will have to let that information sink in for a little bit and maybe come back to it after a period of time, because as I said, there is a huge amount of detail in there. So I think the implications of all of the different elements around budget impact analysis, I think all of our fellowship participants will have to think through, I suppose, in their own time. We have a question from David Wright, and it is, why doesn't a budget impact assessment take into account long-term costs associated with extension of life, or is that another part of government that considers?
We don't generally take it into account, but it is taken into account in some settings, and it's kind of one of those areas that's open to debate, and there are probably arguments both for it and against it. Arguments for it would be that it is an additional cost. If you save somebody's life and they live for 10 years longer, then that does mean that it will cause increased healthcare costs associated with looking after them for that period of time. When we're doing budget impact analysis, we look at the long-term costs of healthcare for that particular indication, but we don't look at the cost of managing other healthcare interventions for the extended period of life. In practice, because you look at something like a 5-year time frame for a budget impact analysis, the costs of the extension in life don't tend to make a big difference. Because you're talking about looking after the primary indication, generally speaking, for those patients for the 5-year time frame of the analysis. And then subsequent to that, the other healthcare costs that kick in when people get other diseases as it goes by, they don't come into the time frame. We absolutely do include them in cost effectiveness analysis because the time frame is longer, it's the patient's lifetime.
Okay, brilliant. Thank you. Can I ask a question? This is from Christopher Chinapu, and it's, how does the financial information flow impact on the quality of impact analysis?
How does what?
The financial information flows.
Okay. I suppose I'm just wondering about exactly what Christopher is looking for there. In terms of financial information flow, what we find is that in different countries there's different levels of information available, and it depends on the structure of the healthcare system. So if you have a health insurance-based model, you tend to have very good cost data available because all of that information is there in terms of driving how the financial flows in the system work. So money follows the patient, and you have costing for all the different parts of care. In other healthcare systems like our own, we tend to not have that level of cost data available. But there is usually some management cost information available that you can leverage off, but it may be of variable quality, and sometimes that's why you need to do a sensitivity analysis around that. And sometimes you need to do microcosting if that data is not available.
Okay, super. Thank you. And lastly, a question from myself is, how has long-term investment in Ireland been affected by decreased or fixed government spending in healthcare?
Well, I mean, I suppose it has been majorly affected. If we were to look at investment in healthcare and in new healthcare programs up to the time of the economic crash, there was like year-on-year major investments in terms of new programs. Since the crash, there has been much bigger emphasis, I suppose, in terms of trying to look at interventions that would deliver improved care without impacting in terms of increased costs. So it's about doing more with less. It's not always, I suppose it's not a bad characteristic of a recession in that it does force us to be more efficient with resources. But it does mean that there were a number of interventions planned to come in over a long time period, which would be seen in some of the longer term strategies like the cardiac strategy that have now been put on hold until there is new money available. And that will have long-term impacts, down the road in terms of morbidity and mortality.
Okay, fantastic. Listen, thank you again, Máirín. I'm going to close it there. We have a few more questions in, but what I'll do is I'll email them on to you and you can respond to them then over time.
Okay.
If that's all right.
Okay.
And just to say thank you very much again for taking part in our webinar. We're delighted to have you. So
okay,
thank you very much,
Brilliant.
and I'll say goodbye to all of our participants. Thank you very much.
Thank you.
Bye.
Bye-bye.